Healthcare Unfiltered, and it's one of our recurring guests who has always provided us with time. And Amer, thank you so much for coming on Healthcare Unfiltered. Truly grateful. You always give us time of your busy schedule. Thank you.
Yeah, thanks so much, Ali, for the kind invitation to be in, I think, one of my most favorite podcasts.
I appreciate it. And I think most people know who you are, but we like to always start by level setting at least your role and how long you've been at Yale.
Sure, yeah. So I'm a professor of medicine. I've been here at Yale for almost 10 years now, and I'm currently the chief of the hematologic malignancies division within the Yale Cancer Center. Clinically and research-wise, I focus on myeloid malignancies, in particular MDS and AML, where I see patients clinically, and I'm very involved in clinical trials for both of those diseases.
So our focus today is MDS. We are going to focus a little bit more on low risk MDS, but we'll probably, we have to address a bit of the high risk MDS as well, which really takes me to ask you the first question, which is, can you tell us how do you decide when a patient walks in the door if they are low risk or high risk MDS?
Yeah, so there are several tools that we have been traditionally using, what we call risk stratification or prognostication tools. So lower risk in general means that the patient is likely to live several years with the diagnosis. And historically, we have not had therapies that improve survival or in a conclusive way in this setting. So the focus of the care has been more on improving the cytopenias, preventing the complications, and trying to maintain quality of life or improve it and preventing hospitalization. Now, high risk MDS, on the other hand, generally the survival is measured in months rather than in years, without bone marrow transplant. Those patients can have a presentation that's closer to acute myeloid leukemia, where they have multiple cytopenias. Generally, all the blood counts would be low, the platelets and neutrophils and the hemoglobin, and those patients would be generally sicker and would be treated with chemotherapy or with allogeneic bone marrow transplantation. So it's a very different spectrum. It's, I think, something you don't often see in cancers, where some patients can live 10, 20 years with just observation, while other patients could die within months, basically, without the right treatment. So because the biology and the phenotype is very heterogeneous, very good risk stratification is important. And the way we did this historically was with the IPSS, the International Prognostic Scoring System, which looked at the basically the blast count along with the cytopenias and the cytogenetics. And this divided the patients into four groups. Subsequently, this was revised into what is called the revised IPSS, which has, I think, better accuracy because it adds additional cytogenetic groups and different cutoffs for the blood counts. And most recently, the molecular alterations, which have not been formally introduced into these prognostic tools in a formal fashion, was added to get into what we call the molecular IPSS, which now has six groups. So we went from four to five to six prognostic groups. But at the end of the day, you really still face a binary decision. So you could have six groups, but you still ultimately will approach the patient as a lower risk or as a higher risk because of the goals of the care that are very different. And with each one of those tools, what has been happening is that we are more upstaging patients. So the percentage of patients who fall into the high risk categories seem to increase with each iteration of these risk stratification tools.
So the low risk is decided based on molecular markers mainly today. I mean, so what type of molecular alterations do I need to find and do to determine if it's low risk and high risk? And is this done by NGS, next generation sequencing, or some other methodology?
Correct. So the molecular IPSS is actually something you cannot calculate by hand. It has to go into algorithm. And this depends on the blood counts as well as the cytogenetics and the molecular features, as you mentioned. So the molecular features basically are assessed through a next generation sequencing. Most of the kind of big institutions and the commercial test will have at least 40 to 50 genes. Of those, 17 are incorporated into, or 31 are incorporated into the molecular IPSS. However, you don't have to have all of them. So this tool does account for missing values if you have certain alterations that are not there. Most of these alterations actually have negative prognostic impact. Of course, it varies to what degree. TP53 is very bad, for example. Um, MLL partial duplication is very bad, while there are only very few things that are good prognostically, such as SF3B1. So you put in the molecular features, the cytogenetics, blood numbers into the tool, and it's actually easy to use. It's online. Within 1 minute, you get the number. And what the number that you get is basically a score. If the score is positive, the patient would be higher risk. If the score is negative, patient would be lower risk. And then depending on the specific group for lower risk, since this is what we are focusing on right now, the patient could fall into what we call moderate low, low, or very low. Very low, the median survival could be on 10 years. So patients could live again a decade with very minimal interventions. Where moderate low, the patients are getting closer and closer to the kind of the higher risk disease.
Got it. So the other thing, are we still looking at back in the day we talked about refractory anemia with ring sideroblast, refractory anemia with excess blast. Are these part of the category? Was mainly used on morphology and other features? Do they hold, I guess, any value in 2025?
Yeah, we still do that. So these generally are covered into kind of what we call the classification, the impact classification. So you have the risk stratification, prognostication, which kind of focuses on giving a prognostic picture for the patient, while the classification is more focused on the disease biology and finding like common phenotypes for the different manifestations of MDS. So we are still using these, the names have evolved over time. So instead of saying refractory anemia, then now we have like MDS with unilineage dysplasia or
Right.
multilineage dysplasia. And as you know, we covered this, I think, extensively on your podcast, about the whole schism that occurred between the WHO and the ICC. And most recently, actually, the good news is that these two systems are being harmonized. I'm actually being invited to a meeting in Chicago in March 2026, where this process is finally kind of being kicked off, which I think is something that is many of us want to kind of, get done with and go back to having like one classification. But to your point, it does not affect the clinical decision making as much as the risk stratification, because you could be refractory cytopenia with multilineage dysplasia, but you still could be higher risk depending on the molecular features, and you would approach that patient as a higher risk. In general, if you have excess blast, if you have more than 5% blast, most of those patients will fall into higher risk.
I mean, you're going to be fresh because you do it March in Chicago, and literally probably 6 weeks later, you're going to be coming to the second annual think tank. So you'll be fresh telling us what actually happened at the meeting in
Oh, and
Chicago.
Chicago is becoming one of my favorite cities.
Yeah. So let's shift a bit to therapy right now. I mean, when we talk about low risk MDS, now that we classified the low risk MDS, the first question that I have in mind, do I need to always treat low risk MDS? Some folks say there are some folks that you could observe, some people would say maybe you could observe some folks. Where do we stand now in terms of the initial decision, observation versus therapy? And then we'll talk about therapy.
Yeah, so my approach to lower risk MDS, like I always say, I always take one step back. And my first approach, actually, or my first step, is to confirm that this is truly MDS, because sometimes you can get, dysplasia. And people often will say myelodysplasia when they talk about myelodysplastic syndrome. So dysplasia means abnormal maturation within the bone marrow, but this can result from many different things, from nutritional deficiencies, from drug effects, from inflammation, from autoimmunity, from other heme malignancies, etc. So I had patients, as someone who sees a lot of second and third opinion, I had patients refer to me with refractory MDS who turn out to have copper deficiency or
Oh,
B12
wow.
deficiency. Or you'd be surprised that, you think people are thinking about this all the time, but sometimes these things are not quite apparent. You have someone with a gastric bypass and, chronically deficient of copper, but nobody checked for it, and they have cytopenias and they have anemia, and and there's dysplasia, and they think it's MDS, and nobody checked their copper, and you give them copper, and they normalize. So I think the first step is to make sure that's the case. We had patients actually with the rheumatoid arthritis as well, the same situation where it affects the bone marrow the same way it can affect the joints or the skin or the kidney. So again, I had patients where once you have treated their autoimmune conditions, the cytopenias and the dysplasia improved. And patients with HIV, again, other or methotrexate for whatever condition, those things can affect how the bone marrow looks and can cause dysplasia. So the first step is to make sure this is truly MDS. What helps you is that if you have excess blast or if you have cytogenetic abnormalities, because it's unlikely that one of these things I just mentioned will give you excess blast or cytogenetic
Right.
abnormalities
Right.
or molecular mutations. Now, once you have made the diagnosis and you are trying to kind of confirm kind of the classification, this is where you need the bone marrow biopsy, and then ultimately you come up with the kind of the let's
Score.
say the risk stratification status
Score.
being
Yeah.
very low, low, or moderate, low. Now, do you always have to treat? The current approach continues in MDS for lower risk MDS that we have no therapies that have improved survival in a randomized fashion. So we do not treat patients who have no symptomatic cytopenia or have no symptoms. Meaning, and actually, I just came out of clinic today and I saw a couple of patients like that where, technically they have MDS because their hemoglobin is 11 and a half and their platelet count is 110 and ANC is 1.1. And a bone marrow was done and it does confirm MDS and they have SF3B1 mutation, but the patient feels fine. The cytopenias are not severe. We currently do not have any treatment that can delay progression of the disease or that can improve survival. And short of this, I don't think any one of us would kind of consider treating those patients. Now, this might change in the future as hopefully we have therapies that are more disease modifying. And I think in lymphoma, I'm not very updated on kind of the literature, but I know, for example, there was also a lot of controversy about treating early follicular lymphoma, and I think many people are still observe them, and then you have the data with rituximab. I'm not sure again where the field stat on that, but I know some people treat like low grade, like
Yeah,
isolated
I
with
mean,
rituximab.
like you said, I mean, there are nuances. So there are some patients with MDS analogous to kind of low-grade indolent lymphoma where you just observe and watch. And these are, if I'm hearing you correctly, these are ones who have reasonable counts. So they're not at risk of neutropenic fever. They're leukopenic, but not neutropenic, for example,
Correct. And we don't
and
see
not
many
symptomatic.
infections, by the way, in lower risk MD for whatever reason. Although those patients could be neutropenic, I have patients with lower risk disease who have an ANC of zero point 0.3 or zero point 0.2 who live like this for years and they never
Wow.
get infected. And I don't fully understand why, because the neutrophils are not only quantitatively low, but also qualitatively, we know there are problems. But there are certainly these patients who, so we generally don't even do primary prophylaxis. Like I don't give antibiotic prophylaxis to patients with lower risk MDS. This is different than high risk MDS or patients on HMA therapy.
Yeah.
But for lower risk MDS with neutropenia, unless the patient has an infection, then I would do secondary prophylaxis, a bad infection. But many of those patients don't need treatment. So even if I have a patient with an ANC of zero point 0.3 and otherwise the ANC, the blood counts are,
Yeah.
let's say hemoglobin of 11 and platelets of, let's say 75, I might not necessarily treat the patient if they are lower risk, especially if they are older, where my goal is palliation. In a younger patient, the calculation might be different, but in an older patient where you do not have a transplant option, I certainly would wait.
You decided now on therapy in a patient with low risk MDS. What is your first line of treatment today in 2025?
Yeah, so this depends on the specific cytopenia you are dealing with. So the most common cytopenia in lower risk MDS is anemia. More than 80% of patients have anemia, and more than half of those patients will require regular transfusions, what we call transfusion dependent anemia. Now, around 10% of patients will have isolated neutropenia or thrombocytopenia. It's not common to have all three cytopenias at the same time that are significant, because otherwise you become higher risk disease. So most of the time it's one or two
Mm.
cytopenias when it's lower risk MDS. So for isolated anemia, the treatment historically has been with transfusions and ESAs. ESAs are kind of the most historically used treatment, short-acting with Procrit and long-acting with Aranes. However, these treatments generally don't work in most patients. The response rate is somewhere between 20 to 40%, and the response duration is around 12 to 18 months. So we've been always interested in finding better options. And in 2025, I would say the most commonly used frontline treatment for anemia and lower risk MDS would be Luspatercept. So Luspatercept is a transforming growth factor beta ligand trap. So this pathway, the transforming growth factor pathway, is upregulated in MDS. It's associated with ineffective erythropoiesis and anemia. And what has been shown with a number of trials we can talk about in detail if you want, is that once you use this drug, luspatercept, this leads to reversal of this ineffective erythropoiesis. This is why this class of agent is called EMA, erythropoiesis maturation agents, and that improves anemia. Now, initially, this was approved in the second line setting for patients with ring sideroblast, and subsequently, based on the COMMANDS trial was the first trial ever to compare ESA to luspatercept as a first-line treatment for patients with transfusion-dependent anemia, and showed a very clear win for luspatercept, where patients had almost 60% transfusion independence with luspatercept compared to 35% with Procrit. So based on that, most patients would be treated with luspatercept, assuming the drug is available. Now, there are some countries where cost effectiveness kind of discussions come at the center of the discussion, and they argue that it's a very expensive drug and you could use ESA and then later do luspatercept. But in the US, I would say kind of the first line treatment would be luspatercept, with the caveat that patients who have an EPO level, so checking EPO level is very important as well as a frontline treatment, because if you have an EPO level above 500 international unit per liter, those patients are less likely to respond to anything really, less likely to respond to ESA or luspatercept. So those patients, we'll talk about this more once we discuss imetelstat, but I would consider imetelstat in those patients.
So tell me a bit about the COMMANDS trial, because this was a prospective randomized study, and you said that the luspatercept showed clear advantage over the ESAs in terms of what? Transfusion dependence, in terms of survival, in terms of what?
Yeah. So the primary endpoint of the trial was these are patients who went into the study. They had to be transfusion dependent, meaning that they were needing 2 units of blood at least every 8 weeks, up to 6 units. So those what we call transfusion dependent MDS. And the primary endpoint was the rate of the patients who achieved transfusion independence for 12 weeks, meaning you have a continuous period of 12 weeks where you do not need transfusions, plus a mean hemoglobin rise of 1.5 grams per deciliter. So this was the primary endpoint. 60% of patients achieved that, so which is again a very good number compared to 35% with ESA. Now, there are secondary endpoints of this trial. Many of them were met. For example, the rate of hemoglobin rise, the rate of transfusion independence separately, not the composite endpoint of the primary endpoint. But most importantly, with long-term follow-up, and this was presented last year in EHA and ASCO, is that we are starting to see some separation in the overall survival curves. Now, this separation is still statistically not significant, and statisticians will tell you there are all kinds of caveats with this look because of the attrition and the sample size. But you are starting to see like some separation in favor of luspatercept. So
Hmm.
while statistically not significant, I think it's very tough to argue that any patient where you have the option of giving luspatercept or ESA, when you have the improved transfusion dependence, when you have the trend on the overall survival, not to give them ESA ahead of, not to give them luspatercept ahead of ESA.
Can you do them together?
So that's actually a very good question. So there are ongoing trials. So there were several lines of evidence. One was kind of, when drugs are available, and as someone who did a lot of health outcomes and effectiveness research, you'd be surprised how often people combine things in real life practice. So it was already happening, and it seems like there is some additional activity. The problem is that this happens in a kind of anecdotal settings without like any clear monitoring of the data. But now there's actually a big randomized study in France where patients, this is in the second line setting, where after ESA failure, patients are being randomized to the combo ESA with luspatercept versus luspatercept alone. So luspatercept alone would be the standard of care now, but this trial is looking at whether doing an add-on strategy of luspatercept to ESA would be better. And in the frontline setting, we actually have an investigator-initiated trial here at Yale that will start very soon. The concept is approved by the sponsor and by the FDA, where we are going to combine RNS. We call it Darbilas. So it's darbepoetin with luspatercept. Patient will get both shots because darbepoetin is given every 3 weeks. And luspatercept is given every 3 weeks. So you get both shots on the same day every 3 weeks with the goal of increasing the rate of transfusion independence plus the durability of the transfusion dependence. So I think this will be something that will be more of interest over time, is to combine these treatments as well as move them earlier in the treatment lines.
What type of side effects an oncologist or a hematologist in the community should watch for when they use luspatercept?
Yeah, it's actually one of the easier drugs to kind of use. I would think of it more along the lines of ESA. We'll talk about imetelstat, but imetelstat is more like HMA in terms of inducing cytopenias and needing more frequent monitoring. Luspatercept is generally easy, it's given sub-Q every 3 weeks. The main side effects are just some muscle aches, but again, generally mild. It can cause hypertension or worsen hypertension in some of the patients who already have hypertension. But I also caution people to kind of not to over read the hypertension issue, because some patients have white coat hypertension. They come to
Right.
you, they are a little bit stressed, their blood pressure is up. So I don't jack up, the hypertension medications unless they bring me a diary. I tell them check it at home and show me a diary before I make a kind of a change. And then the last thing is that some fatigue. Some patients have initial worsening of their fatigue from luspatercept, which I think is probably related to cytokine release. And then this tends to improve within the first 2 to 3 cycles with continued therapy, especially if their anemia response and their hemoglobin rises. So those are the most common side effects. It's very uncommon to have serious or adverse events leading to discontinuation. So this whole thing is closer to ESA compared to some of like drugs like lenalidomide or ESA, or azacitidine or imetelstat.
And generally speaking, to give luspatercept, you have to have the serum erythropoietin, you said less than 500.
Correct. So the command trial we just discussed excluded patients who have an EPO level of above 500. So we do not know for sure it does not work, but the pivotal trial excluded these patients. My best guess is that it would work, but we know that the higher the EPO, the less chance it's gonna work. Even within the commands, they stratified by EPO level less than 200 and then 200 to 500. And the rate
Yeah.
of success with the 200 to 500 is lower than less than 200. So by extrapolation is that if you go above 500, it's
Yeah.
probably going to be even lower. But I do have patients where, again, for different reasons, I don't want to give them HMA or imetelstat. I could still try luspatercept even if their luspa is above 500, but you might get a pushback from the insurance.
It's actually maybe may not be a bad kind of real world observational study to execute on and trying to look at, a few hundred patients, for example, that you guys can look at and see, the level of activity. Although you just told me already in the commands trial, you're essentially seeing activity, but the level of activity is lower as the serum EPO gets higher, but it's not zero. I mean, there's some activity.
Correct. I think it does work in some patients, but as you mentioned earlier, this could be actually a good place where you also could
Yeah,
do combos,
yeah,
rather than
yeah.
single agent to try to kind of increase the chance of response.
EPO over 500 using amlostat?
Yeah, so the standard, like I would say, like the kind of the NCCN guidelines, like would recommend if you have an EPO level above 500 to use either imetelstat or HMA. Now, both of those drugs can cause thrombocytopenia and neutropenia. So you can improve the anemia, but then you have some degree of thrombocytopenia and neutropenia. Now, the degree to which this happens varies, but you still have to do blood work once a week. You still have to kind of prophylax a patient if they become neutropenic. Uh, on some occasions, you might need to give some platelet transfusions as well with these drugs. And so it's a little bit more involved. So this is why, again, some of the older patients might not have the appetite for it. But yeah, I think if the APO level is above 500, this would be the standard approach. But you potentially could try ESA and APO understanding, or sorry, ESA or luspatercept understanding that the chance of success is much lower.
Yeah. What else is happening in low risk MDS? Like, if I ask you, what is, as a researcher, put on your research hat, not the clinician hat, what are the questions that the field of MDS is trying to answer for the low risk category in MDS?
Yeah, there are a number of questions. I think the first question is kind of, do we have to wait until the patient is transfusion dependent and have symptomatic anemia? You asked me at the beginning, is like, do you treat patients who have, let's say someone has an anemia with a hemoglobin of 9.5. The patient might have like a little bit of fatigue, but not significant. Is that someone I would treat? Like most of the time, people would wait until the patient is transfusion dependent before they treat. But now that we have effective drugs, and as I mentioned to you, we are seeing not only transfusion independence, but we might be seeing some survival potential advantage with luspatercept. So there is ongoing questions about whether we should treat patients earlier. And along those lines, we actually have a trial right now, a big randomized phase 3 trial global study called the Element, which is very similar to the command study. The main difference is that it's treating patients who have symptomatic anemia but they are not yet transfusion dependent. So today I saw a patient actually potentially for this trial where the hemoglobin was 8. The patient has some fatigue, but they have not yet been transfusion dependent. And the goal is, or the primary endpoint is, what is the percentage of patients who basically stay or convert to become transfusion dependent. So you are trying to prevent them from needing regular transfusions. And I think this could be a transformative trial because it would be, if it's positive, it would be the first time where we are kind of treating patients in a big randomized trial in patients who are not in regular kind of transfusions, but they have symptomatic anemia. The second direction
What,
is basically
Amer, that trial you mentioned, what is comparing people, the one who
it's the
are,
same like the commands. It's luspatercept against EPO.
the only difference is they're not transfusion dependent.
Correct.
Got it. Okay.
Yeah, the second kind of direction we touched on as well is the combinations. And, now we have luspatercept, we have ESAs, we have imetelstat, which is the first-in-class telomerase inhibitor, which is also effective, is given intravenously every 4 weeks. But as we mentioned, the main issue is that it has neutropenia and thrombocytopenia risk. But the questions are, can you combine some of these drugs and give them earlier? We discussed some of the ongoing trials looking at some of these combinations, and I think this ties into the issue of disease modification. Can you improve survival? There's for example some reduction in the mutations, the driver genes that lead to MDS with imetelstat, and there's an argument that this could be disease modifying, meaning that it could extend survival or it could lower the risk of progression to acute myeloid leukemia. So all of these, I think, are questions
Mhm.
that are being asked. The problem is that you need like very large number of patients to kind of answer these clinical four in 100,000 a year in the US, which translates into 20 to 25,000 cases a year. But these, I think, are two of the most important questions being asked. The third question is about the sequencing. Why is that important? Because as we discussed, ESA used to be the first line treatment. Now we have luspatercept move to the first line because it's better than ESA.
Right.
But how do ESAs work after luspatercept? We don't really
Yeah.
fully know because we don't have like prospective trials that looked at giving ESA after luspatercept. This is actually one of the arguments I get from some colleagues in the community is that we say, well, we know that luspatercept works after ESA works after luspatercept. So should I start with ESA and give
Yeah.
luspatercept after that? My argument to this is that you generally in oncology give your best therapy,
Well, you already have
at,
a
at the front, and then
you already have a randomized controlled trial, prospective study that
exactly, yeah,
demonstrated superiority. So it makes no sense to use ESAs in the front line. When you use luspatercept in the front line, obviously, as you should, how long does it take before you see activity? I presume not everybody's going to respond. I mean, what's the percent of response and how fast do you see that?
yeah. With luspatercept, it's around 60% of patients will achieve transfusion independence. So the way it works is that this is actually something we didn't cover, but with luspatercept, you do kind of a dose escalation. So you start with 1 milligram per kilogram. And then after two doses, if the patient still needs transfusions, you increase the dose to 1.33 and then 1.75. And this escalation was initially based on whether the patient is still transfusion dependent or not. And subsequently, on the COMMANDS trial, was based on the level of the hemoglobin. If the hemoglobin is still less than 10, you escalate.
Mm,
So if you add the different periods, you do around 6 months before you stop the drug because you still need, you do the 1 milligram for two doses, 6 weeks, and then the 1.33 for two doses, which another 6 weeks. And then you do the 1.75, which is the maximum dose for another three doses, which is 9 weeks. If you add this together, this would be 21 weeks, around 6 months before you stop the drug. And speaking of like trials, by the way, we have a trial called the Maxillus, which stands for maximum dose of luspatercept Maxillus, where we are giving the highest dose of the luspatercept from the get-go. So you are giving the 1.75 because we know most patients, more than 60% of patients will need to get to the highest dose to respond.
right.
And we know the drug is quite safe. So why should you spend all this time
Yeah.
at the beginning, like escalating the dose when you can just start from the get-go? This trial is a phase 3B, meaning that it's not a randomized trial, but it has two cohorts, 50 patients each, one in the front line, one in the second line for luspatercept. And we actually reported early results from this in EHA, and additional results will come later in the year. But it seems like starting with the highest dose is feasible, but the FDA label is still with the dose escalation.
It's hard to talk about MDS without alluding a little bit on the high risk disease. Me and you spoke about the VERONA trial before, which really looked at HMA plus venetoclax versus HMA, and it was negative. It was aiming to improve survival, and I think we talked about it. Although I admit I have not seen the paper yet, I just saw the press release from Abby. Has the paper been published? Like, do we know more?
So the paper is not published, but what was presented is actually an oral presentation in Soho meeting. Some of like, the top line results. So only like 7 or 8 minutes of data has been kind of released in, I don't know, like 13 slides, something like that. So there's a lot of data that has not yet been published. There will be additional data releases,
At
throughout the
ASH,
year
I'm
and,
sure.
a paper, yeah. But I think the biggest takeaway messages from Verona, one is, to me, it was surprising, not necessarily that the trial was negative. This is anybody who has done high risk MDS knows the long train of negative trials. So it's never surprising to get a negative phase 3 trial. But what was surprising to me is how close the survival. I mean, this was a very negative survival trial. So the survival difference, like the median survival was like 22 months versus 21 and a half months. Like just like
The same.
the hazard ratio was like 0.9. So it's very similar survival. But also what was interesting is that the complete response rate, the CR rate, was not different between the two arms. It was around 20% versus 18%. And I think there is a lot of data that we need to dissect from this trial in terms of like how many patients went to transplant on each arm. Did the patients who go to transplant benefit more from venetoclax? Because we know it's a better way of reducing the
Yeah.
blast faster. So maybe the best advantage of venetoclax is reducing the blast faster and then taking the patient to transplant. it does seem that patients who had a higher blast count had a higher chance of response if they got AZA-VEN compared to AZA alone. But we need to see these kind of analysis at the level of the overall survival, not only for the response. So I have to say there are kind of more questions than answers after this kind of initial presentation of the data.
You mentioned earlier when we were talking about luspatercept in terms of the mechanism of action, which is it's against the TGF.
Yeah.
And so I'm presuming high risk MDS, they don't have overexpression of TGF. That's why we don't really try that in high risk, right? I mean, if it's target against a
Yeah.
particular receptor or particular protein, I'm have to assume that in high risk MDS, I don't have overexpression of TGF.
Yeah, so there has been discussion about doing trials like this. I think there's some hesitation because there have been trials where you added ESA to azacitidine in high-risk disease and it didn't seem to help. And there are trials where we added tipomimetics, basically. So eltrombopag to azacitidine in high-risk
Yeah.
MDS. And not only didn't help, it's actually the patient who got the compo had worse outcomes. So it's not always 1+1 is better in MDS. So I don't think there's a lot of excitement to combine with azacitidine, at least in my own kind of
Yeah.
view, unless there's a very clear rationale, as you're saying.
Amer, my last couple of questions are just more about what's your observation in terms of who's treating low risk MDS? Like, I mean, are you seeing, as a referral physician, tertiary center, you don't see these patients, like unless they come to you. In other words, like the community physicians are comfortable managing these physicians on their own, or are you seeing there's like confusion, they need some guidance? Like, what's your observation generally from where you sit in terms of how this is being done in the community for a community oncologist who don't really see this every day? I mean, MDS is not the most common disease. They're going to see like breast cancer or GI cancers.
Correct. I think we have a special situation here at Yale because Yale, we have the main campus where I work, and we deal with the most aggressive kind of cancers and the most sophisticated clinical trials. But we also have a large network of sites across the state. So I know many of these physicians. They are part of our umbrella. Some of our trials, like for example, the commands was not only open for us in the main campus, it was open in all of these 14
I
kind
see.
of sites across this state. So these doctors will often reach out when they have questions. They will often send us the patients for consideration of clinical trials. But outside of this specific situation, you are right that most of the lower risk MDS patients will generally be handled in the community. And because they don't see many of those patients, we do see some problems. For example, we see people, they don't check EPO level. They just go ahead and give ESA
Yeah.
without even looking at EPO level. We still see a lot of people giving ESA instead of luspatercept as a first line treatment. I still see patients who don't get escalated, so they get started on the low dose, the 1 milligram per kilogram, and they stay on it for months, although they are still needing transfusions because nobody remembers to kind of escalate the
Interesting.
dose. Yeah, I see patients, as we discussed, getting all kinds of combos like ESA with AZA, with Luspa, with, and even with imetelstat, um, I see again, people starting with the lower dose rather than the higher dose. So it's very interesting. And I cannot blame, the community docs because as you said, I mean, they probably see one patient every couple of months compared to I don't know how many lung or breast cancer or colon cancer.
Yeah.
So I think this is an issue that probably applies across rare diseases. Probably the same thing with CLL or I don't know, like with AML. With I just saw today a patient with AML who was on venetoclax continuously for 2 months. No, nobody stopped.
Wow.
Kind of,
Wow.
So I think again, it's very tough to kind of to kind of uh, keep track of everything that's happening across the field. And I think the solution is to work with experts, try to refer
Yeah.
patients to make sure you are doing the right thing as a community doc.
Did we cover everything about MDS, specifically low risk disease, or did we forget anything? I mean, I think we talked about therapy, frontline therapy with luspatercept. We talked about community approach, side effects, mechanism of action, the COMMANDS trial. and as well as future studies. Anything else you think that is important to cover that I may have missed?
Yeah, I mean, I think we covered all the kind of the most important things. I just maybe kind of give a couple of words about lenalidomide, which continues to be an important option for deletion 5q. This is a drug that has been approved since the year 2005, so almost 20 years now, but still a very effective drug. The
Wow.
problem is that del 5q MDS is relatively rare, 5 to 10% of patients. And imetelstat, we touched based on this. This is an approved drug since last year. It's very effective for transfusion-dependent anemia for patients who have high transfusion needs, and it's intravenous every 4 weeks, but it can cause significant neutropenia and thrombocytopenia. So you have to do weekly CBC prophylaxis, potentially transfuse the patient, but the rate of transfusion dependence with it is around 40%. And then there's a number of, second-in-class agents with other transforming growth factor inhibitors and other agents such as PK agonists, uh, F inhibitors such as roxadustat. So I think there's a lot of interest in additional drugs because none of these drugs we mentioned are curative. Most patients will need an additional therapy within a year or two. And
Mhm.
it's, I guess similar to what happens in myeloma, where you are sequencing the patient from one line to the second line to the third line.
And you continue
So
therapy until disease progression, right? Like with luspatercept, it's not like, time limited.
correct. You continue until disease progression. And even when disease progression happens, you give another treatment, you give HMA or something else, because again, those patients are going to
Yeah.
continue to have symptoms and complications of cytopenia related to MDS.
Well, kudos to you and to all the investigators who really work on MDS. I mean, when I was a resident, I mean, we had really nothing. I mean, like literally nothing. We would give Procrit and GCSF and things like that. But I like how you framed it as disease modifying, right? Because now you have an underlying pathobiology of why the disease is happening, and you're really trying to target that, and that's really key in really
Yeah, we
making a
certainly
difference.
made, I think, made a substantial progress. But again, we always look for the better, and you get
Right.
jealous when you look at AML with 14 drugs and myeloma. I don't even know how many drugs they have, or CLL. So I think we still need, especially with high risk MDS, I think we certainly kind of need to make additional progress.
That's a good jealousy. It means that you can go back and now get to work. Well, Dr. Amer Zeidan, thank you so much for coming on Healthcare Unfiltered.
Always my pleasure. Thank you.